So just an overall overview. We'll do some introductions, and then we'll tell you a little bit about Synapticure. Dr. Mahant will tell you a little bit about CND, and then we'll talk about the Syn-One Test. So my name is Dr. Jaime Martin. I am a movement disorders neurologist and the former director of movement disorders here at Synapticure. And Liz, if you'd like to introduce yourself.
Yes, hi, I'm Liz Ferluga. I'm also a movement disorder neurologist, and I'll be stepping into Jamie's role, which will be new to me. So I'm happy to be here.
And then Padma, we'll let you give a little bit more information in just a moment. I'm going to introduce Synapticure, and then I will pass it off to you. So hopefully those of you who are joining us already know about us at Synapticure, but for those of you who may be new to us, Synapticure is a virtual patient and caregiver-centered teleneurology clinic, and it was really founded by patients for patients with the goal of addressing the gaps and the obstacles in the care journey and the treatment journey for patients and their families, and to really provide support to navigate the complicated healthcare landscape. We provide accessible, compassionate, and personalized care to patients, to their caregivers, and their loved ones. And for anybody living with conditions like Alzheimer's disease, related dementias, Parkinson's, Huntington's, ALS, and more. And our focus is really a true comprehensive care approach. We do a multidisciplinary support team. We have subspecialty trained neurologists. The goal is to really build personal relationships with patients and their care teams. Every one of our patients gets a care navigator who helps quarterback every aspect of care. We have mental health services, clinical trial education. We do referrals for clinical trials as well, genetic testing and counseling, and more. And it's really, the goal is for that to be at the convenience and the urgency that you need in every community and in all 50 states. And our mission is to provide compassionate, ethical care to persons living with neurodegenerative disease and to help advance the field of diagnostics and treatments supported by science and evidence-based medicine. And as part of this mission, we really want to educate our community about various diagnostic and treatment options, which is what brings me to our speaker today. So Dr. Padma Mahant is a movement disorders neurologist with Foothills Neurology in Phoenix, Arizona. She serves as clinical assistant professor in neurology at the University of Arizona. Her training includes medical school at the Medical College of Pennsylvania of Drexel University, her neurology residency at the University of Rochester in New York, and her fellowship in movement disorders at the Muhammad Ali Parkinson Research Center at Barrow Neurological Institute, where she's also served as part-time faculty for several years. She's expanded her education and research efforts by taking on the role of Director of Medical Affairs at CND Life Sciences, where she works part-time, and this allows her to continue to provide both direct patient care and private practice, as well as participate in research and what she's going to tell us about today. So Dr. Mahant, go ahead and take it away.
Thank you so much for having me. I appreciate both of you in terms of your involvement in Synapticure in particular, and really trying to cover the gaps in care that certainly I'm seeing as a movement disorder specialist in Phoenix, Arizona. And I think it's going to be an increasing issue moving forward with the increasing incidence of Parkinson's and other neurodegenerative conditions. So thanks so much for what you're doing. So I'm going to talk about the Syn-One test. I'll talk also about CND within the course of this talk, give you a little bit of background on the lab that we have here in Arizona. But really, the Syn-One test, I think, is potentially a new era in the diagnosis of Parkinson's and related conditions. And I learned about this test through my esteemed colleague, Dr. Todd Levine, who's one of the founders, along with Dr. Gibbons and Dr. Freeman, from Harvard, and they've been in the area of neuromuscular research and clinical work for really decades at this point. And on the movement disorder side, we're not so used to doing skin biopsies. The neuromuscular folks really are and have been for some time to diagnose neuropathies, and they determined that they could potentially use this same technique to help with diagnosing Parkinson's. And so now we have decades worth of research that has shown that this really can be helpful in terms of diagnoses for these conditions. So we'll talk about that. So just to sort of set the stage a little bit, and really, again, applause to Synapticure for covering much of the gaps that we see in terms of access to care. But we certainly see that there has been an increased incidence of Parkinson's. We previously thought this was about 60,000 per year in terms of Parkinson's specifically, and now we recognize that this has shot up to 90,000 per year. And this was based on CMS data from 2019. And of those patients who are diagnosed, less than 10% are actually seen by movement disorder specialists like Dr. Ferluga and Dr. Hatcher-Martin. We're all movement disorder specialists, and so less than 10% of folks diagnosed with Parkinson's are seeing specialists like ourselves. And 40% don't see a neurologist. So that 40% are with primary care docs who are really at the front lines of diagnosing and seeing patients with their very first symptoms. And it can be, unclear in the beginning in terms of what these conditions will wind up being in terms of diagnosis. And so this is a graphic that shows the geographical variations. This is from 2012 in terms of that PD incidence. And so, if you're not close to a multi-specialty care center, it really can be difficult to get the care that you need for some of these conditions that really require specialty care. And I love that Synapticure has the specialists to help with this and the care navigators to really help patients find care very specific to their conditions. And of course, access to care is difficult in terms of rural areas. And we also know that there's regional differences in incidence at this point that could reflect potentially different levels of exposure to environmental toxins. So there may be sort of hotspots where care is really needed. So there may be a multi-specialty center that's close by, but it may be a year to get into these specialists because there are so many people trying to access this care. So I really applaud Synapticure for filling these gaps. So the other issue to sort of that sets the stage, I think, is the fact that we know that about 30% of patients in terms of Parkinson's and related conditions are misdiagnosed, particularly early in the disease process. And this can be neurologists as well as movement disorder specialists. Although movement disorder specialists may do a little bit better, we still have the potential for misdiagnoses in terms of early stages of these conditions. And so that really leads to this graphic here that shows us, early on, there may be some tremor, there may be some slowness in terms of the first motor symptoms of these conditions. But even before that, there may be some prodromal conditions that we're increasingly recognizing. So REM behavior disorder, 10 to 15 years prior to these motor conditions, can start. Constipation, depression, loss of sense of smell. And so these conditions really can predate the motor symptoms. So is it possible then that we could identify these earliest clinical pictures and then correlate that and potentially help with diagnosis even before motor symptoms start? And then we could potentially move the needle in terms of treatment, in terms of slowing the progression to these motor symptoms. And so once we get to that stage of diagnosis, when it's clear, when the patient has, let's say, tremor, stiffness, slowness, then it may not be as necessary to, diagnose these conditions with a specific test if the patient is responding quite well to medications. But even then, sometimes patients will evolve. So we might think that these patients look like typical PD, and then they start evolving and developing other symptoms, eye movement abnormalities or ataxia. And we may wonder about the possibility of an atypical Parkinson's. And so at that point, we might want to consider a test that can help us with diagnosis. Also, if we're considering DBS, if we want to make sure that we have a condition that can respond to DBS, we might want to consider that as well. So really, this graphic here highlights the fact that this idea of diagnostic accuracy can be really helpful throughout a patient's clinical course, so early on as well as later on. And then the other piece of this is that increasingly we're recognizing that condition-specific therapies and clinical trials are really demanding better diagnostic accuracy so that we can make sure that the treatments that we're looking at are looking at those treatments in the same patients, so that we don't have a patient with PD versus PSP versus MSA, that we're really studying the specific treatment in a specific population to make sure that we're seeing the right signals in terms of the treatments that we are testing. And so objective evidence certainly can help with the clinical diagnosis. I think many folks are familiar with the idea of imaging, so MRI, DAT scan, potentially PET scans if available, genetic testing, certainly if there's a family history, can be helpful. And now we have the potential to look at pathology, and that's really what the Syn-One test is. And this involves the actual detection of phosphorylated alpha-synuclein, which is a mouthful, but it's basically a protein that we see in these conditions. And I will highlight those conditions and what this protein is throughout the course of this talk. And so that pathology can really be seen in multiple tissues and fluids. And what we're focusing on with the Syn-One test is the skin. And so CND Life Sciences really has a strong scientific background. As I mentioned, the three founders have a background in neuromuscular conditions, and it was founded in 2017. It's headquartered here in Scottsdale. Sunny Scottsdale in the 90s right now. So many of our snowbirds may be in other states, and I don't blame you right now. So this is a lab that is CLIA certified and CAP accredited, and it's credentialed in 49 states. New York State has some special certifications that we are working on presently, some steps to go through for that credentialing, although many patients can have the test in terms of research studies within the confines of a research study. So CND has been awarded 3 large NIH grants, and we'll talk about a publication that came from one of those grants. And the Syn-One test was launched in 2019, and to date has been ordered by over 1,500 clinicians, and over 15,000 tests have been performed to date. So this is just a look at what the skin biopsy procedure is. It's performed in the office. So this is an office-based skin biopsy procedure, convenient compared to, going into the hospital for radiology scans, nuclear imaging injections of a radio tracer, spinal tap. So it's a little bit easier in terms of this being, a 15-minute procedure. Lidocaine is used to numb up the area, and then 3 3-millimeter punch biopsies are taken. No stitches are involved with this, and there is Medicare reimbursement with existing pathology codes. So this really goes beyond biomarkers. It's really looking at and detecting abnormal synuclein. And so it really is the only commercially available skin-based neurodiagnostic test that aids with the diagnosis of these 4 synucleinopathies in particular: Parkinson's disease, dementia with Lewy bodies, multisystem atrophy, pure autonomic failure, and REM sleep behavior disorder is also a synucleinopathy. As I mentioned earlier, that's considered a prodromal condition. We're in the process of looking at that in terms of a study presently at the sensitivity of the Syn-One test in this condition. But as far as the specificity and sensitivity, it's greater than 95% for those 4 conditions in orange. The techniques have been supported by several publications and multiple researchers over the past decade. Beyond just CND labs, there are some other labs around the world that have studied the same or a similar technique. And these are the 3 sites that are involved in the Syn-One test. So the posterior cervical, or just at the base of the neck, just above the knee, and just above the ankle. So those are the sites that your doctor would identify, localize, and then take those 3-millimeter punches from. That's the size of that, about that 3 millimeters compared to a quarter, that little red dot there. And this is in the orange there, you can see the phosphorylated alpha-synuclein within the nerve fibers. And we'll take a look at that a little more closely. And so we see that greater than 95% sensitivity and specificity across those 4 synucleinopathies. And so this was the big publication that just came out last month in JAMA. This is called the Synuclein 1 study. So this is the first of those 3 NIH-supported grants that supported this study. And so this is a multi-center study that looked at across academic and private practices, looked at patients with those 4 synucleinopathies. So Parkinson's disease, dementia with Lewy bodies, multiple system atrophy, pure autonomic failure. and found that that sensitivity was significantly high, very, very high. So for across the synucleinopathies, it's 95.5%. With Parkinson's disease, 92.7%, multiple system atrophy, 98.2%, dementia with Lewy bodies, 96%, and for the pure autonomic failure, and this is a condition that is considered a peripheral synucleinopathy, the proportion of patients testing positive there was 100%. So that basically showed that we're able to detect through that skin biopsy positivity in terms of that phosphorylated alpha-synuclein greater than 95% of the time. And in patients who did not have a clinical diagnosis of a synucleinopathy, it was found only 3.3% of the time. So we would call those healthy controls. Now the question is, are those patients at risk in the future of developing something? That's something that we don't know, but we will be studying the Syn-One Test longitudinally in a couple of studies coming up, and I'll mention those briefly at the end. So this really did show in a very large study, multi-center across academic and private practices, that with a clinical diagnosis of these conditions, we really can detect and correlate those diagnoses with this test. And so just a little background in terms of what we're looking for with this Syn-One test and where that term comes from. Syn-One, so synuclein essentially is what that test indicates there. And so what we're looking at here on the left, many of you have probably already seen this diagram or something similar. On your left, there is a normal picture of a substantia nigra with that dark substance there that really consists of those dopamine-producing neurons, and that's the main issue with Parkinson's disease. And so what we find in the cells that have dropped out is this, or the remaining cells, is really this Lewy body, which is the pathologic hallmark that we see with Parkinson's. And so there's neuronal dropout, and the basis of that, we think the pathology is this Lewy body. And so that's found in those surviving nigral cells, as well as other neurons, and immunohistochemistry can really identify that abnormal protein. And that can be found in Lewy bodies as well as Lewy neurites, and that is exemplified here on the bottom. And that pathology can be seen not only in this part of the brain on autopsy, but it can be seen throughout the nervous system. So central autonomic enteric nervous system, so the nervous system of the gut, and as I mentioned, the nerves of the skin. And so what happens with that protein? Why does that lead to this pathology? Really what happens is this normal protein that we all need of alpha-synuclein, it's needed, we think, for synaptic transmission. So basically communication between nerve cells. So the normal alpha-synuclein does serve that very important purpose. And when it's folded, you can see here this graphic at the top. It's perfectly fine. It serves a biologic function. When it becomes misfolded, when that protein is abnormal, then it can become quite sticky. And when it becomes sticky, it can clump together to form these Lewy bodies or glial cytoplasmic inclusions. And that actually results in the damage or the injury to the cell. And that potentially can be passed on from cell to cell as well. And so just another graphic looking at that. So at the top there, you see the normal soluble alpha-synuclein monomers, and this can form oligomers and then fibrils, and that's where you run into the potential problem of Lewy pathology resulting in that neuronal dropout. And so this is considered, again, one of the pathologic hallmarks of Parkinson's, the Lewy body, and the accrual of this abnormal insoluble alpha-synuclein, but also potentially the loss of that normal soluble alpha-synuclein can be an issue. So this may be why some of the early efforts we're seeing to really harness this abnormal alpha-synuclein may not be doing what we want it to do, because we're not necessarily addressing the problem of the loss of this normal alpha-synuclein. So this is going to be sort of an ongoing focus of research in the future. So then getting back to what we see on the skin biopsy, now that you have the basis of what's happening on the protein level with these nerves and neurons, What we see here in the left corner is the PGP axonal stain. So what that does is it actually highlights the nerve fibers. So that green squiggly line here is a nerve fiber. And then the red here is actually looking for that abnormal protein. So that phosphorylated or misfolded alpha-synuclein is what you see here in red. And so what we want to actually determine is whether that alpha-synuclein is showing up, that abnormal alpha-synuclein is showing up in nerves. And that's what we see here. So this is the merged intraaxonal or within the nerve fibers, that phosphorylated alpha-synuclein that you can see here in these orange beads or gold beads here within the green. So that is a positive P-Syn fiber, co-located P-Syn with a nerve fiber. And so this can help us with diagnosing Parkinson's certainly, but potentially other conditions as well. So for patients who are developing potentially sleep disorders, for example, we talked about REM behavior disorder as an early sign potentially of a synucleinopathy. And so we can potentially differentiate REM behavior disorder, potentially clinically and through a polysomnogram, but also through this test. So if we can identify that P-Syn in those nerve fibers, it can help us differentiate from periodic limb movements or night terrors or other parasomnias. And then looking at cognitive disorders, you may know now that there are new treatments for Alzheimer's. So it's going to be very important to determine if a patient with mild cognitive impairment has Alzheimer's versus could they have an early dementia with Lewy body syndrome happening. So we also want to identify whether there could be, potential for other conditions as well. But I think the idea of using this test potentially in MCI, mild cognitive impairment, to differentiate especially between dementia with Lewy bodies and Alzheimer's is important because the treatment is so vastly different between those two conditions. For autonomic dysfunction. So autonomic dysfunction involves disorders of blood pressure, so potentially dizziness with standing up, constipation, bladder issues, erectile dysfunction. So sometimes that is the very first sign of these conditions. And in a patient with diabetes, for example, let's say they develop some new symptoms and we're not sure, is it due to the diabetes or could this be a new condition potentially happening for them, like multi-system atrophy or dementia with Lewy bodies or pure autonomic failure, or even Parkinson. So this can help identify that. So if that protein is seen, we can differentiate that potentially from these other causes of neuropathy. And then, as we mentioned, in movement disorders, so if a patient has a tremor, let's say they've been started on a medication that could be potentially causing that tremor, or let's say there's a family history and there might be a genetic condition like a spinocerebellar ataxia, or we're worried about an essential tremor, then finding this protein really can help us with determining whether this could be a movement disorder that's based on this abnormal protein, that's caused by this abnormal protein that we see with Parkinson's, dementia with Lewy bodies, and multi-system atrophy. So really, this is a diagnostic tool to help with those main conditions. So REM behavior disorder, potentially we can identify Parkinson's, dementia with Lewy bodies, multi-system atrophy, and pure autonomic failure as well. So just to kind of wrap up with a couple studies that we are recruiting for now, the other two major NIH-supported studies that we're looking at. These are longitudinal studies that are sponsored by CND and supported by the NIH. The first is the SYN-Sleep study, and this is looking at 80 patients with RBD or REM sleep behavior disorder. So we're going to try and identify those patients in terms of whether we can detect P-Syn in patients and what happens over time as well. So we see that in smaller studies, we can potentially identify it in other centers about 70% of the time. And so we're going to take a look at that in patients with RBD, both clinically defined as well as by polysomnogram. And then we're going to follow those patients over time to see if things change, both in terms of their skin biopsy, but also in terms of their history. And do they actually evolve into some of these conditions that we mentioned, like Parkinson's, dementia with Lewy bodies, or multiple system atrophy. The study, it goes over 2 years. So there's 3 visits, baseline 12 months, 24 months. And so it may be too short of a time to see a lot of patients convert, but we'll get an idea for, based on when their symptoms started, we might be able to catch some of these conversions. And then the other study is the CND study. This is a study that looks at cognitive impairment, mild cognitive impairment. So these are patients clinically that we think either have dementia with Lewy bodies or Alzheimer's disease. And we're going to take a look a little more closely at those patients with the skin biopsy at baseline and 12 months to determine, again, can we differentiate these populations on the basis of the skin biopsy, not only clinically, but also, looking at PSYN in particular, and what happens to those patients over time as well. And are there differences as well in terms of their clinical picture and what's showing up in terms of the skin biopsies? We did find, for example, that patients who were more severe in terms of their symptoms had a higher quantity. So we'll be able to characterize that in terms of severity potentially as well. So really, just to sum up here, I think we're looking at a new diagnostic paradigm with these conditions. And that's what really motivated me to join CND, seeing the potential benefit in some of my patients in getting to me earlier, getting their diagnoses a little bit earlier, and then potentially enrolling in clinical trials and having that ability to sort of know what they're dealing with, that better and greater diagnostic and prognostic clarity for patients at the earliest stages. And with that, then patients can make more precise and individualized treatment decisions, potentially lifestyle changes, so diet, exercise. Sometimes this can be really helpful in sort of initiating those changes. And potentially it might allow for avoiding unnecessary and costly tests and procedures as well. And then finally, we're hoping that this provides hope. So really connection with others on the same journey. So being able to get into support groups, into educational groups, and to participate in clinical trials that really could be, again, sort of moving the needle in terms of disease modifying therapies. And of course, our hope always with this is to slow and potentially even halt symptom disease progression. And so with that, I will take questions, and thanks for your attention. Hopefully I didn't go too much over my time here.
No, that was fantastic. Thank you very much.
Pleasure. Thanks so much for having me.
So we have a few questions, but maybe Dr. Ferluga, maybe we can start. Talk a little bit about sort of as a neurologist, right? How, or even, specifically as a movement disorders neurologist, how might you use CND? Could it be any different how we use it in, in an in-person clinic versus, how we do it at Synapticure with telemedicine?
Yeah, absolutely. I think that there's a lot of utility in using this. I mean, I came from the training of watchful waiting, and that can be really hard on patients when, especially if you see someone and they have a lot of gait predominant symptoms, and you're like, well, I think you have this. And a lot of times people go away without having a diagnosis. And what I'm hearing a lot, even in telemedicine now, is that people are kind of unsatisfied with just a exam as being a clinical diagnosis.
Yeah.
And they're just like, they barely looked at me. They just watched me walk down the hallway, and then I got diagnosed with Parkinson's. So having something that has more diagnostic certainty, I think, is very helpful. And I think it can be really helpful in situations like essential tremor. And sometimes when we're looking at something where we may see like an overlap syndrome where people have essential tremor and some Parkinsonian symptoms, and you're thinking about treatments, this could be really helpful. Also in things like that could be very difficult and change prognosis. And like going back to someone who has gait predominant Parkinson's versus something that is a Parkinson's plus condition such as PSP or CBD, a lot of times those other symptoms don't come till much later. And to have something where it can point you in a direction, I feel like could be very helpful, because before this test, our test was like a DAT scan. And unfortunately, that just tells you have a dopamine problem. It doesn't necessarily tell you which dopamine problem you have. And we also are seeing more patients who've been exposed to neuroleptic medications, for example. And there's always kind of a question about, was this going to happen anyways? Was this something that got unmasked, or this is from the medicine? And I do think that that would really impact how you treat them, right? Because if it was positive, then you might go down more a road of Parkinson's, versus if it was negative, you may try to be more aggressive with talking to the psychiatrist about seeing there's other medication options. And I feel like at doing more telemedicine, you can do a lot over telemedicine with the exam, but having an additional test to give people kind of that diagnostic certainty, and even like about prognosis, I think that's really important. And I do completely agree with you that I think when people are more confident in their diagnosis, they're more likely to make those important lifestyle changes like exercise. And we know that that's such a key in delaying delaying progression.
I think that's actually a really good segue into some of the questions that we have. So one of them is, and you kind of alluded to this a little bit, Dr. Mahant, about in some of the studies, you're looking at how things change with a biopsy over time, but can you use the biopsy at this time to understand the progression of any of these disorders?
Right. So the studies have not been longitudinal to date, but what we do know is that we do see with increased time since diagnosis, we see higher distribution and quantity of P-Syn deposition. And so that was true for multiple system atrophy, for Parkinson's disease, and for pure autonomic failure. Not so much for dementia with Lewy bodies, and we think that may be because those patients from the get-go have pretty high deposition already. And so we're not seeing that correlation as much, but certainly over time, we see higher deposition. We see more severe symptoms as well, and that is motor symptoms, so defined by the UPDRS, the Hoehn and Yahr. We also see greater symptomatic orthostatic hypotension, worse quality of life, increased RBD symptoms. And so those all seem to correlate with this deposition that does increase over time. So that was looking at patients in terms of the onset of their symptoms within the JAMA study. You know, how long did it take for those symptoms to develop and then to come to biopsy? And so they correlated basically looking at those times and the amount of deposition. And so that was really across the synucleinopathies, we saw that increased severity correlated with the increased P-Syn deposition and quantity.
And I'm going to combine a couple of questions together because I think you could probably answer them with the same one. Can you use, you've talked a lot about MSA, PD, Parkinson's disease dementia or dementia with Lewy bodies. Can you use this skin biopsy, or is there another skin biopsy that can be used to diagnose PSP, or so progressive supranuclear palsy, or corticobasal degeneration, or CBD? And then somebody actually asked about dystonia as well.
That's a great question. Presently, this study in particular, this Syn-One test, looks for that phosphorylated alpha-synuclein. There have been some groups that have looked at tau as well, which is what we would be looking for PSP and CBD. I don't think that that's commercially available yet, but on the research level, that is being looked at. And so that might be a direction that our lab will head to at some point. We're not quite there yet in terms of being able to provide that differentiation. But we can sort of differentiate potentially in terms of saying, yes, there is phosphorylated alpha-synuclein here in this skin biopsy. One thing also to point out is that there is the potential for mixed pathology at times. So there may be a synucleinopathy. There may also be a tauopathy. We see that on autopsy studies as well. So So having a synucleinopathy does not necessarily rule out a tauopathy if you're thinking about it clinically. So that's just an important note to consider. And so that's where potentially being able to, see and find and detect tau protein as well would be helpful. So so we'll see more to come, I think, on that as we see these research studies sort of unfold.
Great. And there's another question, and again, I'm going to combine a little bit here. Let's say you have we think it's Parkinson's disease, but somebody who has a genetic form versus maybe somebody who's had an environmental exposure, or maybe they've had trauma, right? Which we know head trauma can increase the risk. Can the test be used to differentiate between different causes or etiologies of Parkinson's?
That's a fantastic question. That is something actually that we're looking at. We don't know yet. We have a feeling there may be some differences. The PPMI showed us that, for example, LRRK2 is not, those patients with that mutation, we may not be able to pick up that protein in the spinal fluid. And we think clinically, although we haven't done those studies yet, we're in the process of doing those studies. Potentially, we might not be able to pick it up in some of these conditions where there is, for example, the LRRK2 mutation, and there is this whole brain first, body first idea of where Parkinson's starts, and does it start peripherally versus does it start directly in the brain? And so we may not be able to pick it up in those cases, potentially like LRRK2, where it might be more of a sort of brain first etiology as opposed to a body first etiology. We're also we're partnering with some folks to be looking at TCE and Agent Orange. We're hoping to study some veterans who may have had those exposures, and we're looking to see if we might be able to identify some differences there. There are some theories about inhaled versus ingested toxins and whether that looks different. So it'll be interesting to see, potentially based on route of exposure, are we seeing differences in terms of the biopsies? And so those are unanswered, great questions, unfortunately unanswered as of now. Potentially, though, that might be why we're seeing, a slightly lower sensitivity in straight Parkinson's patients, because some of those, and that's 92.7%. So, we might be missing some of those cases because of that difference in terms of that route of exposure. So the excellent question. And then I'm sorry, you had asked a question about dystonia, and I didn't fully answer that, but we don't have a way, unfortunately, as of now, to diagnose dystonia, but there may be, some electrical studies, EMG based studies that can help with that diagnosis as well. So.
And then another question that came in, I think this is especially relevant. You mentioned before, let's say somebody has diabetes, so they have some other diagnosis that may cause them to have, a neuropathy, right, or something wrong with the nerve. So is it common to have a positive Syn-One biopsy and also have like a type of neuropathy that you might see in another disorder?
That's a great question. So the test looks not only for PSYN, but we also look for what's called a small fiber neuropathy. So we can actually determine the nerve fiber density at each of those sites that I pointed out. And so we can commonly see a neuropathy, for example, with Parkinson's, with dementia, with Lewy body. We don't see it as much with multiple system atrophy, although it can be present. But we also do absolutely have to think about the other causes of neuropathy. So it may be that a patient has Parkinson's, but they may also have diabetes, and that may be the cause of the small fiber neuropathy. We aren't able to determine, looking at those nerve fiber densities at this point, whether it's due to Parkinson's versus whether it's due to diabetes, for example. But we are able to identify certainly if there is neuropathy, and there are certain patterns that we're seeing in terms of that neuropathy that can help us differentiate potentially Parkinson's versus MSA. There was another study that I didn't put in here that was published about a year ago that looked at this same skin biopsy procedure, the Syn-One test, in MSA versus PD. And we did see a wider distribution as far as the location of the PSYN in those 3 biopsy sites, for example, in MSA versus PD, where we might only see it at the neck. And so that's why it's important to do those 3 different sites as opposed to just 1. So a patient may wonder, you know, I'd like to just get 1 of these punch biopsies rather than 3, which is completely understandable. But it is helpful in terms of potentially differentiating further in terms of what type of Parkinson's a patient might have, a related condition. And so we're going to be doing more evaluations of the data that came out of that Synuclein-1 study, where we hope to be able to look at that in even more detail. But it is looking like that same pattern that we saw in that publication based on the study looking at the cutaneous signatures with MSA versus PD. It's looking like that's going to hold up. So that in particular can be helpful again in early cases where we're not sure where things are going to go. Or PD patients can have orthostatic hypotension, for example. They can have autonomic symptoms. So is it a case of PD developing some of these symptoms, or could it be a multiple system atrophy, which again, we want to treat potentially a little bit differently and maybe consider other clinical trials for that population.
There's another question about sort of 2. Can I ask my doctor for this biopsy, and what if they don't do it? How do I find somebody that does?
That's a fantastic question. And there may be some clinicians out there that aren't comfortable with doing this study, but certainly, you know, might be interested in the results of it. And so we have developed a sort of clinician network at CND Life Sciences. So we do have a number of clinicians that are open to referrals for the skin biopsy. So we can certainly help finding a clinician that would be able to do this test. There are potentially dermatologists as well that might be able to do this test. Let's say you're in, you know, a rural community and there's not, you know, another a movement disorder specialist, and there's not multi-specialty care, but maybe they have a geriatrician who's used to doing, you know, all kinds of skin procedures, and they have no problem with doing this. Or a dermatologist, then we're happy to try and link you up. And you know, if you want to give us a call and say, hey, I had this doc do this procedure, it wasn't my neurologist, but it was a dermatologist, please let us know. We're happy to take their information down and pass that along. So absolutely, you know, I don't think that this necessarily has to be done by your clinician. You know, it's certainly a test that can be done by any clinician, and also nurse practitioners and PAs are increasingly doing this procedure. So if there's not someone in your office that feels, you know, comfortable doing this, you can always look to, there's another organization that's fantastic in trying to help fill the gaps in care called AMDAP. Which I'm sure Dr. Ferluga and Dr. Hatcher-Martin, you're familiar with. And so this is a group of movement disorder-based PAs and NPs that are interested in helping with this procedure as well. So would be happy to connect you to any of those groups or other clinicians.
Fantastic. And I think you briefly touched on this, but is this covered by insurance?
Yeah, so it is covered by Medicare codes. It can be quite, different in terms of commercial payers as well. But we have a benefits verification department that can look into that for patients and for clinicians. So, you know, just give us a call if that's something that you're concerned about, and we'd be happy to get that process, in motion. We're looking, of course, to increase that payer support to make things easier for patients. And we're hoping, really the convenience of this test and knowing that this procedure is cheaper, for example, than, a DAT scan. This potentially in terms of healthcare dollar utilization, we're hoping will drive some of the payers to consider this in terms of coverage so that patients aren't faced with that burden. If there is an out-of-pocket portion for the Medicare patients, it's usually less than $300 or so to date. And so we're hoping again to hopefully we can get, additional support for patients so there's less of that burden on patients.
We had another question come in. What constitutes a positive test? One orange axon at one biopsy site or a greater number of such axons at more than one biopsy site? And how many axons are present in a typical punch biopsy? I don't know the answer to that one.
That is a great question that the pathologists would be able to answer as far as the number in particular. There is a certain density that we have on the report in terms of the nerve fibers per millimeter. I don't have those numbers off the top of my head, but that is listed in the report. But as far as really one positive co-located nerve fiber with PSYN is all that's needed for a diagnosis. So, so there are certainly potential for multiple, but it is abnormal for PSYN to be present in nerve fibers. So there is a quantification that the pathologists use of it's essentially sort of like a 0 to 4 scale where they are counting, literally counting these co-located fibers across the stained sections. And so we have a way of quantifying that. And interestingly, we have partnered with a company called Visiopharm to harness AI capabilities. This is very hot, of course, these days, but we want to use it for good. And so we're hoping to use that in this neurveillance strategy, using AI to help point in the right direction, point to these nerve fibers for the pathologist to be able to reduce the time needed for reading these. It'll still be, looked at by pathologists certainly, but if we can enhance that whole process and be even more precise in terms of counting those specific fibers, then we're hoping to be able to provide even more data, for example, looking at those signatures where we're potentially able to differentiate the different types of synucleinopathy.
So question, so as neurologists, right, we like to look at a lot of interpret a lot of our own data. We like to look at our own MRIs, our own DAT scans. I don't know how to interpret a biopsy. So is there somebody that can help as a clinician? Is there somebody that can help us? Obviously we get the report, but is there a way for as clinicians to talk to somebody about some of the details or have any questions answered?
That would be me. Absolutely. I am absolutely happy to talk to clinicians about the reports. And we encourage this for an initial biopsy for all clinicians. We don't force them. We're nice about it. But I think that it's helpful to go through the report in some detail in terms of what we're looking at, in terms of looking at those distributions, what this might mean. I love to talk through cases because I always learn as well. And although we are seeing very clinically defined cases in these studies, certainly in real life, patients follow different clinical patterns and may not fit these particular patterns specifically from a clinical basis. And the pathology may look a little bit different than what we, sort of expect, for example, for an MSA signature versus an idiopathic PD signature. So we can really talk through these cases. And that's really been the basis for identifying, some of where these studies sort of originate in terms of looking at these signatures is hearing about the clinical patterns and then seeing that it's actually linked up to idiopathic PD versus MSA, for example. So the founders, Dr. Levine, Dr. Gibbons, Dr. Freeman, have been, looking at these cases for, again, over a decade now, and colleagues coming to them saying, what can you tell me about this? And then identifying those patterns and then using that to really study this in, a blinded study to really show that, yes, we can actually identify and help with diagnosis.
Great. And then there's another question about, maybe I missed this. Does this tell us the level of dopamine we have or how much has been lost?
That's a great question. Unfortunately, it does not. It doesn't really give us an idea of dopamine. That really would be sort of more the DAT scan in terms of helping with that. The quantitative version of the DAT scan potentially can help with that. And so I don't know how clinically useful that is in terms of guiding treatment per se, but it may give you an idea of potentially, some severity as well. But this does not look at dopamine at all.
Okay. And there is a question about will this presentation be available later? We will post this on our website. We'll share it with CND so they can share it as well. We'll post it on all of our social media sites as well. So you will be able to watch that back. Probably won't be up until the beginning of next week, though. Okay, so I think that's all. If there's any last questions anybody has, or if Liz, if there's anything else you'd like to add.
No, I was just going to say that was a great presentation, very helpful.
Yeah, this is fantastic. I think it's really timely. We have a lot of patients that are asking for, right, like you alluded to before. They want more information, right? It's you want objective information. So I think this is a fantastic presentation. I can't wait to hear how some of these new tests, the new trials go.
Absolutely. Yeah. That's why I, decided to join CND, because I saw the benefits directly in my practice, for many patients. And I'm hoping, again, if we can move the needle in terms of getting some of these disease modifying therapies moving in terms of, defining these populations that can benefit, so that we really move towards precision diagnostics. I think that's very needed. Certainly from my standpoint as a movement disorder specialist, and certainly from the standpoint of other neurodegenerative conditions, it's important to identify these conditions early on so we can get patients to the right treatments.
Yep, absolutely. And the earlier we can, make adjustments and make some of these modifying treatments, then I think, the bigger difference we can make right there. The earlier you make a wrong turn, the further you get, away from the direction you're headed. So in this case, that's a good thing. So.
Right. We absolutely want to point patients in the right direction. And if that means, at the earliest stages in this RBD, population, if we can get diet and exercise, those two things, potentially if we can find a motivating factor in terms of, getting that lifestyle change started, I think that can be really helpful. And sometimes, folks need that boost. They need that understanding, that level of understanding to really make a lifestyle change. And so hopefully this will provide more information to make that change in a positive direction.
There's another question that's, I think, an interesting one. That it's saying that I was diagnosed with a DAT scan 7 years ago, and now my husband has been diagnosed with primary autonomic failure with skin biopsy. Can this be environmental?
Yeah, that's a great question. I think, that is something that we're interested in. We see those, regional differences in terms of incidence. Certainly that was looking at Parkinson's. As far as sort of the company it keeps in terms of, PD and pure autonomic failure. Pure autonomic failure may be a prodromal condition as well for Parkinson's and other sort of more central synucleinopathies, whereas pure autonomic failure is kind of considered more peripheral. And so, that again could be a prodromal condition. And so certainly environmental exposures, I think more and more we're seeing evidence of that. And hopefully there is a bill that's moving through Congress that I think it's in the Senate now. You may know better than me, Jamie, but I'm hopeful that will get passed, because that means potentially we can address some of these issues and get to the idea of prevention.
Absolutely. All right. Well, I think that's all we have. If there's any last, I know there was a question about clinical trials. I know you mentioned a couple of the clinical trials that are going on, but there's a great place to look for clinical trials in general about Parkinson's disease and related disorders is Fox. It's part of the Michael J. Fox Foundation. So if you go to foxtrialfinder.org or .com? .org.
And also clinicaltrials.gov is always a really good one too.
Yep. And then clinicaltrials.gov will have everything. The Fox Trial Finder has a lot of information. It kind of walks you through, so you can put in your information. It'll really walk you through all of that. But sometimes there may be some delays in updating that. So clinicaltrials.gov is usually the most up to date But sometimes you have to know a little bit more about what you're looking for in order to comb through all of that. So, and always ask your clinicians. For those of you who see us here at Synapticure, we're always open to discussing, anything, whether it's skin biopsies or clinical trials or other treatments that are available. Please don't ever hesitate to reach out to your clinicians. These are the things that, we want to talk about and we love to educate on. So I think with that, we're just on time. So we will end there. Dr. Mahant, thank you so much for joining us. And
thank you so much for having me and for everything you're doing at Synapticure. We're really happy to, help in any way for patients and clinicians that, may have difficulty accessing, multi-specialty care, advanced specialty care. We're happy to help and partner in any way we can. So thanks for everything you're doing.
absolutely. And just as a reminder, we will send out to those, we'll send email out links to the study, to the presentation today. We'll do a summary on our website, and then you'll be able to view the video on a variety of social media platforms as well. Thanks so much for everyone joining us today. Take care.
Everyone,
All right.
good night.
Good night.